board?
I believe so.
All right. Good morning, everybody. It's minute after 8, so let's go ahead and knock this off. Hopefully, we won't have to use that as funeral. But welcome to the Education Committee on February 4. We have a quorum.
You have quorum.
Cool. First of all, before we say, is there any public comment? And
Nothing online.
Did not. I don't know if this meeting's officially started.
Big gavel guy. Adoption of the next order of business is the adoption of the February 4th, 2026 agenda. Adopt the agenda. Anybody?
So.
Okay, do I have a second?
Second.
Awesome. I have a motion and a second. Anybody opposed to the adoption? Hearing none, we will consider the agenda adopted. Consent agenda. As you see, the notes were taken out. It's basically to approve the minutes of the December 3rd meeting. Do I have a motion to accept the consent agenda?
Motion to accept.
I have a second. Okay, motion and a second. Any discussion? Any opposed? Moving that along. Okay. So we'll move. Report and discussion. We've got a couple business items, main part of the meeting now. We had a working group meeting up at MPHPI a few weeks ago talking about education on neonatal resuscitation. It varied adopting a nationally recognized card class like NRP or NOWS or something like that, all the way to not, why do we need to do it? Because we only have 3 or 4 patients a year. So I wanted to bring it back and have a formal discussion in a notice meeting to try to figure out what next steps should be. Set the stage there, and if anybody would like to jump into that, jump in. Thoughts?
So one of the things, just so everybody's kind of aware, as it wasn't at the meeting, one of the things I brought up is I used my team. We researched every neonatal call we ran in the last year. I ran 4 at maximum, given a little bit of leeway on one of them. It was a 1-month-old patient, but the mother didn't know the birth date when our crews were there, which is not atypical for Northtown. We've all worked that. So I'm going to say we had 4 total. The one where the mother was unsure about the birth date was a congested baby that ended up in a non-transport. We had 3 deliveries, 2 delivered before our crews got there, 1 delivered at the hospital in the ambulance bay. None of those turned out poorly. Our vital signs and everything turned out pretty good on those. And none of them were should be considered high acuity, in that OB calls are often handled by basics. They're taught in EMT basic school. And the 4th one I had was a non-transport. Can't really define that as high acuity. So with the consideration of the infrequency of it, and I can only speak for my own department and the data I found, to say that we need a card class that would cost my department tens of thousands in research hours, I think our time and money could be spent better in other ways. That was kind of the point that I made through the meeting. I was also the only one in the meeting that had clear data. That's not fair. Derek Cox had pretty good data about what city ran, but nobody else was able to get data on how many neonatal calls they ran the last year. So we can't really define what the issue or problems might be if we don't have the data to go with that.
Other thoughts?
I agree. Like, we don't have system-wide data, or like we don't have data from every agency that we are able to generalize into a system. I would be hesitant to like mandate that we have to continue to carry a card class, rather than just modifying it to what an agency needs.
And just to add to what they were saying, I was at that meeting too. And while we did have some things that were identified that needed to be added to education that I think are valid, warming of babies, that seems to be one of our number one things, airways, so on and so forth. I know that after that meeting, because I found it really kind of powerful information, really, we've already started talking to our instructors about when you hit that topic, these are these things we need to really hardcore hit, probably harder than we have been, just to start it from the ground, the grassroots level of EMTs and advanced EMTs. But I agree. I think it's expensive. And if someone's not going to be, it's an expensive little venture to go into a card class if education is really what we're needing, and as they said, no real hard data that we could really trace things back to. But I think increasing education is always a good thing. I don't think that ever hurts anything. The more we know, I think that's how we make the system better, and we maybe reduce some of the things that if we're seeing them, that we can correct some of that stuff to the best of our ability, and then reinforcing that within the agencies, within the upper level educations, I think would be most valid. I don't think a card class more than what we already have and whatever is required is necessarily necessary. So just my 2 cents.
Where's Derek? I thought I saw him.
Walked up.
Why are you not up at the table, buddy?
Morning,
Hi.
we're being represented.
Okay. All right. So I have a couple of thoughts on this. First of all, the goal of our organization here, our committee, is to try to make the system better. Everybody agree? Try to feel shortfalls, try to identify them and come up with sensible solutions to those issues, right? I don't know that I agree with a card class for neonatal, but I would say that one of the biggest things that we're facing there is we have a very low frequency event, but a very high acuity event. And so we need to be really good at what we do. And the only way we do that is to provide really good training. Okay. I don't know that card classes necessarily provide that high level of training depending on the piece. So it's very variable. The example I would use is on the fire side of things. How many times do we cut into a roof in a year? Not very often that I'm aware of, at least when I was fire and this stuff. And how much training do we do on cutting into roofs, and how much money do we spend on it? So that when the situation presents itself, we're really good at what we do there. I think we need to take that same approach when we actually make them. So one of the thoughts I had, and I've talked with Brian and these guys a little bit, is what if we reached out to our subject matter experts, the neonatologists and the pediatric emergency room specialists, and ask them what they're seeing. What are the top 3 things that they're seeing on a consistent basis that they would like to fix pre-hospital? They came up with 3 or 4 things or 2 things or whatever it is. Why couldn't we discuss those 3 things and develop a curriculum as the education board and send it out to everybody to integrate into their deal? So I've been here for 30 years. We've always talked about data and not being able to get it. We're not very much further ahead now. So we can't wait for that, right? But if we have such a subject matter experts that say, these are the problems, we can fix it, develop a short hour, 2-hour class to directly assess that, get it out to everybody, let everybody put it into their system the way that they need to. And then we measure the progress, see what we did good, see what we need to improve. But at least it's a start. It's kind of a compromise.
Troy, just a question. don't we have, I mean, most of our courses that we teach have a curriculum or have a whole section on that. And this is not going to be popular. A course is only as good as the instructor that teaches it. A course is, what I'm saying is, if I got somebody that's sitting there that's, I give them a class, and I agree with you, there is never any issue with more education. I will stand behind that 150%. So I agree with you on this. If we have something. But again, we've got to make sure that if we're going to do this, we're not just clicking through something and saying, okay, well, it's mandated, we got to go through this information. What we really need to do is those that are teaching our FTOs. FTOs are key in this, key. Our folks that are precepting are, I myself right along included with it, our instructors, we need to buy them into what the importance of this is. And that when you're in this section, you really need to hit this information. I don't necessarily think we don't necessarily have a curriculum, because all of us that are teaching a course or doing continuing education have that. We know kind of, and I mean, even at our meeting, we had one of our subject matter, and I apologize, I totally forgot her name.
Morning.
Thank you. She gave us some really good indications of some of those things that, and we've known really kind of where the issues kind of lie. But I think that if we, as educators, if we just really kind of hone into our instructors, our preceptors, all of our educators, our folks out in the community that are partners with our doctors, our nurses and stuff, if we can get them really to kind of buy into the educational side of it, because I don't know any instructor that hates when they have to do, I mean, not all, because I don't mind it, but hates the OB section of any class. Oh my gosh, I got to go through OB. I got to go through childcare. I got to go through the questions and stuff. But teaching them that this is really important stuff, and then maybe having that filter down. I agree, having maybe some set points to hit, but I think we really have to hone in on educating our educators that when you get to this stuff, we've really got to hit this hard. I don't know what I don't necessarily know what the answer is other than that, but I'm all for more education. I don't know about mandating stuff necessarily, because then it becomes, again, with some of our agencies, you start mandating classes and so on and so forth, then you got to pay them to come in and do it and all that, which, it's part of their job to do this stuff. So I don't know. I said, I'm not necessarily disagreeing, but I'm disagreeing on a mandate. I think we have curriculums. I just don't know that we're necessarily doing it to the extent that it needs to be done.
I think the curriculums are probably a little bit too broad. They're not specific, especially specific to our system and what our doctors are seeing our crews bring in. And I think if we could nail that down and get it a little more specific and come up from the education committee with an hour and a half long thing. These are the things that the doctor's seeing, pay attention to this. This is how we fix it, all those kinds of things. And I think we're actually trying to do a little bit of work to make the system better. But everybody represented, and everybody's working on the same problem. Everybody knows what the problem is clearly identified, and we can start trying to see if this works. Maybe it won't work. I mean, we got grease board stuff all the time. Looks really good on grease board. When we put it into practice, we don't know how it's going to actually work out, right?
Right.
But we got to do something, because what we're doing right now isn't working. Okay, we're getting the same complaints, the same issues coming from those doctors that they're coming in cold, they don't have a line, all those kinds of things. So we've got to either turn our head and put it in the sand, or we got to do something about it. So
Reach out to Dr. Horning, Dr. Jensen at Sunrise, and just ask. Just ask it.
so, I guess somebody could make a motion. I'm not supposed to make a motion, I guess I can, but I would like to reach out to the subject matter experts from all of the hospital chains, all the pediatric guys and gals, and get their top 3 or 4 concerns, bring that back to the next meeting or whether we have a working group or not. And work on that curriculum and then get it out to everybody.
I think you need to add to that. Each agency represented here, and even those not represented here, have the ability to determine what gaps are existing in their current education.
Sure.
Versus what is happening within their own within their own agency. Johnny, you got 4 calls, and what's going wrong? Address those issues. We can use our subject matter experts from the hospitals to help inform our decisions, but you're all empowered to do the same thing: is to address the gaps between education and what you're getting. You mentioned they're coming in cold and no IV. That's addressed in education. So it's not being reinforced. We're already telling them, take it. You have a baby warmer in your truck. I hope you do. And you should be able to use that thing, or at least know when to use it. So there are gaps here, and it may not be in the education, it may be in the implementation. So all these things need to be put together in kind of some type of DMAIC kind of thing. You have to determine what the problem is and then measure your results, right? That whole process. What I'm hearing here is I'm not going to say nebulous, but pretty close. We're not addressing this situation based on the data, what's going on. We have anecdote, which may be accurate, that we're making our decisions on. So y'all know what you're doing, y'all know what your data is, and you have educators who address those gaps. So we can certainly support any decision this board makes, but again, mandatory education, a card class that costs money, these are all considerations that have to be taken into effect before we implement it on you have to do this basis. You have my 2 cents.
And one of the things I would offer, since we're talking about education and maybe putting buckets in, maybe not. Without question, the neonatal calls is the least amount of calls that any of our agencies run. And by no means am I saying they're not important, but I will push back that they're all high acuity, because the experience I had is that they're not, the calls that I ran were not high acuity. They're unique, they're rare, but they were calls that by education standards, any ECT basic could have managed. I have a meeting tomorrow to discuss our cardiac arrest survivability. We ran 220 that we reported in Epstein last year. We run more than that, but that's trauma stuff. I looked at every agency in town plus national averages for where we're at in those Utstein reports. None of us are in the elite status, but every one of us runs at least 1 code a day, if not more. Those are high acuity lives that we can save. So if we're going to start focusing on where we can make the biggest impact, I think trying to understand what are our most frequent calls that lead to bad outcomes. Todd ran a meeting a couple meetings ago about innovations. Those have drastic impact if they go forward. So I don't fully understand why we're focusing on one area rather than gathering data to our highest criticality, our most frequent, where we can have the biggest impact. And that's part of the problem. You'll never hear me say no to data. You'll never hear me say no to education, especially when it is data driven. But if we if we make changes without data first, it's now a belief-based argument that we can't quantify. Was the an outcome due to the change in education, or is it just a guess? We'll never be able to say what change was effective, what change was not, and why are we going to continue doing things? That's dogma. Research.
Other thoughts? I'm just trying to know. Not all I wanted to about high risk and low frequency cases. You go very wrong, no liability and things like that downstream. But I think it is this. There's the concept nationally of the pre-hospital pediatric readiness, which is not just education. That's what is the system like? Do you have care coordination? What is your equipment? Do you have pediatric sized equipment on your ambulances? And I don't know, are we looking at that? That's typically up to individual agencies to look at, but that whole concept of getting what's called PECs, the pre-hospital emergency care coordinator, pediatric emergency care coordinators, which look at all of this stuff. And I think in the absence of enough, I guess, if you case volume, I don't think anyone has one of those individuals working for their agency. Very, very helpful that happens individuals, but the absence of that, I think it's going forward and kind of deciding which agency needs. I could also say on the national level, a lot of the focus is going towards simulation on these events because they're just not enough. There's just not enough of the actual clinical cases.
Mhm.
Just like you train on cutting through a roof, you train on doing it over and over and over again in a simulated scenario. I don't know that we've standardized that. We, in a system, we can't mandate that. It's going to be a I guess I just chime in just to say that, you know, not the only ones with this issue, but I think Troy, you're saying get a lot of calls and complaints, people come back from the different hospitals. I know we haven't heard of that from at least the health district, so I don't know.
But there's a reason that it's on the agenda.
Yeah, understood.
If things are not going well, because we wouldn't be talking about it, number one. And it may not be 100 of them, and I'm just not focusing on just this issue. I think that template for any issue that we decide and we look at, could be looked at. And we could talk about the data here, talk about it. Education could be the best way to solve cardiac arrest or being better that way. And provide suggestions.
To Doc's point, he's not getting complaints to the health district about us doing bad. You're saying that we are doing bad, but what data supports that we're failing?
Or maybe like everyone's just like, you know, it's like if everyone's kind of watching their house, right? Maybe there is a bigger issue. Maybe we don't need the specialist to tell us. Maybe if we can just review this in QI directors or whatnot, but we say, hey, there is definitely a trend here. There's transport time missing out those fees for the cardiac arrest. What are those issues now we improve? You know, again, if you're going to keep out your uses your one provider or whatnot, it's a level thing. But if from the trend standpoint, if multiple agencies are getting multiple issues about the issue, then we can look at it, QA it, identify it, you know, define it, and then you know, work on education.
Well, and I mean, you don't tend to hear about the one misstep on adult cardiac arrest, but you tend to hear about the minor screw up on a larger scale, right? Halo, high acuity, low occurrence scale. We hear about that because it's rare, it's infrequent, and now we can talk about it. But when somebody misses an IO on an adult cardiac arrest, all right, well, we ended up hitting the other leg and life was good. We moved on, right? But we've heard about this specific example because it is so infrequent, because it is so rare that those mistakes are per capita a larger percentage of the failures. But is it when you extrapolate that data to a so?
Sorry, Dr. Horning is online. He's trying to speak.
Dr. Horning, go ahead.
Good morning. I just wanted to add to what Christian has said. So the EMSC committee for the state of Nevada has developed a hospital pediatric resident readiness program. We have 4 levels, and we are rolling it out this month. And hospitals will have to show that they have the right equipment and the right drugs and everything for children, and then they will be recognized by the state and get a certificate. The next step we have is to do that for pre-hospital pediatric readiness. This is a national program, and we are trying to institute it in our state. So that's coming. The second thing is I would agree that having a card, and which is incredibly expensive for all the agencies and only happens every 2 years, is probably not the way to go. But I think if we all coordinate and look at what we're seeing are issues within the agencies and also at the hospitals, then we could formulate and assimilate a program so that we can address those things in a minimal amount of time with our training officers that and do it on a regular basis so that people feel like they have the skills.
Dr. Horning, you mentioned the pre-hospital component of that the state would like to initiate. Is that being funded by EMSC dollars?
Yes.
Is there enough EMSC dollars to support the entire state?
Yes.
Well then, awesome.
Mm-hmm.
Anything else, Doc?
No, I just think that there's a lot of people in our community who are willing to help in any way that we can, because these are infrequent events, like you said, and they're high acuity events, and in any way that we can contribute to people getting the confidence to handle them, because it's all about confidence, we are happy to do so.
Any other thoughts?
For when it comes to training and the different training programs, like is there a set number of cases and simulations of certain cases or?
There are, yeah.
Guys do it?
Yeah.
Stuff, FISDAP and their charts and things mandate a, education wise, a number of different scenarios. They have to complete.
Okay, yeah, 'cause that's what I believe
The
that-
problem is not really initial education. I think it's ongoing education and
sources count. Educational centers, pre-hospital have access to these simulators, with ambulance or what otherwise, but I know there's educational resources and medical education, medical history, at least two. NG has, 31,000 square foot simulation center facility, that, it's unused a lot of the time. They have great. What they were, first year was coming in and running cases in their simulation center with subject matter experts, like local in the facilities that were kind of running these cases. And said, hey, we're going to run through the pediatric, 3 cases. And now we have all their simulation centers in town. I feel like there's local. But
any other thoughts? Where do we go from here, then?
Just gathering the subject matter experts. A little more time for the individual agencies to get some CQI process done.
I think that's difficult in getting call. How do we know? I mean, figure if you just run a call and pull all your patients with an age of less than 0.25 years, if we can't find those calls.
So in Image Trend, I had to go through and filter out all patients with an age of 1 month because it's hard for me to do days. Right, like, so, and then I had to look at every call I had for 1 month, which was quite a bit more, right? But not laborious. I've got a team. I did it on this case. I had to go through and filter each single PCR to look at the birth date to make sure that it was technically a neonatal. That's how I got 3.5, if you will. It took me a little bit of time, but it's not, I mean, it's doable, at least through Image Trend with the report writers that we have, it is doable.
Can you share, what was kind of getting?
So I had 4 neonatal calls for the entire year of 2025.
Just searching for calls.
I had right around 40 that equaled that 1 month ordinance. So 10 times as many, right? When we're talking 110 to 120 calls a day through my agency, it's not a huge amount.
Education. Oh, but still, as well. So, but I think that's a start. Like what's on it, and I hear the background thinking through like the ESO, you can try and pull out data that way just to see the pulse numbers are going non-transport. There's kids that worry about non-transports and the parents signing out and do this. There's many other social issues. Just starting with the bread and butter, like resuscitation of sick kids. I think it would be low, just an individual agency just to be what you did. You can find 1 month or less. 40 is not a completely unreasonable number to look through and to see how many people less than 10 days, less than 5 days old, whatnot. And see how your local outcomes are. I think it starts by kind of looking inward and seeing how many cases and what happened to them. And then looking for those trends, like places.
We just did,
Don't make me.
we just did 20 days of pediatric simulations and neonates. And so it was obvious whenever the crews came in that like the NRP style algorithm, that's not their thing. And then after the 4 hours, they could pretty well recite it. Then we're going to just have to follow back up on it. I'm not going to have a neonatal simulator again, but I'll have two of the sim babies still. And so we'll probably just have to do it on that. But then I think at least LVFR wise, we'll do an formative assessment, pen and paper at the beginning of class next quarter and like see where we land on that like college retention.
I mean, and sort of buttoning this all together, because we were talking about creating buckets of hours, we were talking about mandating certain things, we were talking about this. The idea behind adding training to neonatal resuscitation would be theoretically, we would solve a problem, right? We would solve a cold baby problem issue. But that doesn't mean we're not going to have other halo style events that are high acuity, low occurrence that we now identify are issues. Maybe instead of saying, well, we have to do 8 hours of peds that nobody could find anywhere prior, maybe we do 2 hours of high acuity, low occurrence training that shifts naturally as the high acuity situations change per agency. And that would require intra-agency data, sort of determining what the high acuity, low occurrence calls are, maybe with input from the Southern Nevada Health District from complaints that have been lodged about pre-hospital care. Now we have a comprehensive picture that's not North Las Vegas, Henderson City. It's a system, high acuity, low occurrence, because maybe you're not having neonates today. Maybe that was city's plague last year. But next year, all of a sudden, everybody in North Las Vegas is having babies and neonate and problems. And so by doing it as a system approach and identifying these issues as a whole, then we can focus CE training on those issues that come up individually throughout the scope of years, as opposed to right here today in 2026.
So that's my idea. We're starting to do, we do Halo events with every one of our students that are precepting. We do 3 steps for each one of them. And this month I'm bringing in 1 crew a day to do Halo events with just my staff and a crew. So we have focused training. It'll take me time to get to everybody, but that's my goal.
And it would be great too if like your partners in private Halo events, at least with some sort of standardized curriculum, so everybody's reading from the same playbook when they were at all.
And we involve MetaQuest in every we're training.
It's awesome. And maybe that's the way that it's at least adaptable. So we're not solving the today problem and then stuck with the today solution in 2030 when we have a different problem.
Yeah, well, like I started with, our job as an education committee is to find issues and solutions. At the end of the day, that's what we're trying to do. Have everybody from all of the agencies here to have input and to say what they're seeing, what they're doing, and we need to use this as a think tank to come up with solutions and things that can fix things. Neonatal just happened to be the first thing that came up. That's not the only issue that we have to have. If we're really looking at it to make it better. So I think we can use the neonatal thing carefully and start to identify other things through the UIQA committee and through our discussions as a group. And then, okay, so we have A, our N is this, what are we going to do to solve it?
Yeah, no, and that would be great input from QA/QI, because that's the meeting where we learn about the occurrences problems where we have issues. We don't get that. We don't need patient information, but a summary of these were the calls that commonly had issues, whether it's opiate overdose, whether it's OBGYN, whatever it is. And then we get a report that then we can develop standardized curriculum that then goes. That's probably the way. And instead of calling it neonatal, because then you're stuck with kind of something that you're anchored to, call it something that's more high acuity, low occurrence, starting with neonatal, and then it shifts naturally.
Anybody have an issue with that kind of a thing, that kind of a direction? So is there any of the agencies that not want to look at their data? So for our next meeting on neonates, bring it in over the last year. Brian and I can talk to subject matter experts at the hospital, see what they tell us, how many times that they're seeing X, and get the N number from them. Discuss that at our next meeting, figure out what we're going to do about it. That sounds like a logical.
I wasn't sure how you were gonna filter the data for dual responses. So you don't want to overinflate our number. I simply give you how many children we ran or under the age of a month, and so as AMR and community,
Right.
it's going to look like far more complex.
It would be double.
patient. So that's why I kind of held ours back. 'Cause I wasn't sure how you were going to scrub that.
Theoretically, run number, unifying, right? Like, because the,
So I think, I don't know if it.
We do. We all have the same CAD.
Yeah.
Okay.
because everything's routed.
Well, with the exception of city, if I'm not speaking out of turn, would you run that based on the transporting agencies? Because that would be the complete follow through, wouldn't it?
I mean, it.
I don't know how the data
Format that I
gets
sent
filtered.
to Matt when he asked for it after the last meeting, I just created a spreadsheet and I put run number, dates, age, who transported, whether it was us or Medic West, wasn't a transport, yes or no, and then vital signs and a brief little synopsis. And so if we can put that through a spreadsheet, then that would all be easily clean upable, right? Like you could start excluding based on, was it a transport, who transported? If it wasn't a transport, who did the report?
Because the run number, even if it's a dual, isn't, the run number is the same for both agency, right?
Always, that's.
Yeah.
So if we could filter out the duplicates,
But ultimately, it shouldn't matter transport dual response if you're tracking a countywide system. You know what I mean? Like if you're trying to aggregate. 500.
yeah,
Both of us were on.
right.
If you add the incident number and just control for duplicates, that's pretty.
Right.
Can you send out that template again? That he used or whatever, and then we'll try looking for the same data then.
Matt, if you want to share what I put out there for everybody, if you thought that was a good template.
Yeah,
'Cause I don't know if I have everybody's email address to kind of put it out there.
when I originally asked for that information, I just got it from EMSC, like Emergency Medical Services for Children from EMS.gov.
Oh, wow. That's already.
It's almost like there's systems in place.
So everybody agree to that? So the next meeting in April, we will start to review that data. We'll have data from the SMEs, from the doctors at the hospital. We'll start to try to identify what we want to do about it.
And also later on, it's just an emerging trend of the QI director today, and it's 11, and just data. And
Yeah,
issues or problems.
and like,
Like I said, the top three types of calls and.
yeah, I was just trying to keep it workable and manageable, right? Instead of just. Anyway, and then I think we can use this as a template for any other issues. We want to look at cardiac arrest and how we're doing on resuscitation. You know, it doesn't matter, the template doesn't change. Right? Take QI, we look at our data, we identify our problems, and then we help write some
Training help.
training so that we're somewhat on the same page. Because we all wrote calls together.
And were we saying all of 2025 then?
I would say for a year, yeah, I would think.
But we're gonna. It's not for
New, you know?
Is that?
Oh, no shit. That's.
We don't.
I don't know, the age cutoff. I'm wondering.
I think it's.
I printed out.
That's it.
There it goes. Just out of curiosity, I printed out the top. I don't think it covers pediatric calls, but I didn't have, that's not fair to say. I don't want to speak as an expert.
Derek, just for Las Vegas Fire and Rescue, we don't mind sharing the data. We would like it aggregated with the whole system before it's sent to this committee.
I think it's adult, but I mean, I can't.
The CARES? It's adult. Yes. Probably.
I'll find out.
And just another.
Everybody but Henderson from what I can find. So I have pulled out, like I broke down, I have a meeting tomorrow, so I broke it down for my chiefs and I have a couple copies of Medic West, us, city, county, and national just the national average, because I can pull all that data. Everybody can, who's on that registry pretty easily. Because I needed the information for a meeting I have tomorrow, so I thought it seems topical from just.
And so I have one question based on, Derek's. How do we aggregate that?
You just have to strip the identity, I think, is what he's asking for, is to strip the identity of the agency that ran it. Maybe a run number though, at least so it's traceable back, but he doesn't want Las Vegas Fire, North Las Vegas to be put last. I think that's what he meant by aggregate.
The only, and I don't mind that.
Yeah, essentially.
I don't necessarily mind that at face value, but it might skew the data if we think this is a system problem versus hey, my agency shit the bed last year. Like it just did really bad. I wouldn't want to impact the entire system because I didn't train my people. So that has to be part of the discussion. Now that could be a private discussion with just a couple people who understand.
If we're finding one specific hotspot.
Yeah, nobody here wants their agency put on blast, especially if they're finding areas on their own that they're trying to improve. But before we make system-wide approaches, we need to know that it is a truly system-wide problem, not an agency problem. So there has to be some discussion outside about that.
That's why QA/QI is closed door, right?
Yeah.
So like that data needs to be discussed there. And then these folks can come back and save this. We can generalize this to the entire system, or LVFR, you got to buckle it up, before we mandate or suggest that someone teach a specific curriculum.
Yeah, and QA/QI would be the perfect committee to be like, no, this is an us problem. This is a we problem behind closed doors. And then SNHD or QA/QI, similar how we share board reports, could share this system-wide issue that all training for the next year.
What ability does SNHD have to be able to, what ability does SNHD have to verify that the data that's being presented to QA/QI is the full picture?
You have an incident number, I can look up the call.
But y'all can't look at like the past year for an entire agency or pull
System.
that or system.
What data do you,
Or I mean, like if we wanted to see just like compliance with our own QA/QI metrics on the neonatal resuscitation protocol we have now, are y'all able to filter through reports, PCRs and see the entire system as like a whole or like
Pediatric breathing problems.
Yeah.
I don't think so. I'd require another add-on like a first pass kind of, which I don't have access to. I'm unsure if the ESO repository is that robust. That would afford me that opportunity. I can look into it, but I don't think it's there yet. Additionally, when agencies change platforms or there's an update to your platform, it stops transmitting. So I have to figure out who's missing and when, and then we have to redouble those efforts to get those charts back in. So there's a data fidelity issue anyway. So I think if we bring these data forward, it would be more bang for the buck if it's agency data specifically. I can look at certain things, right? But I think until we get the ESO side, the repository nailed down to where it's more effective as a QA tool, I'm gonna have to count on you guys to actually bring those data forward.
Okay, any more discussion on this?
I don't know what the rules are. I don't know if it's possible for a representative from the education committee to go to the quality assurance committee and that they drive these topics from home. As opposed to, I love our doctors 100%, but if you speak to any specialist, they think that that's the subject that we need to drive education on. Hemorrhagic stroke, if you go to an IR facility, that's an elective. We've got pediatric trauma surgeons, they think that's the subject. If we let the outside drive it, we will be doing this every month. But if we let quality assurance drive it, then they're looking at the system as a whole, not their specialty. And so we've never asked for that. I've never heard quality assurance come out and say, hey, the system needs education.
Yeah, I agree, Rebecca, but those specialists, I stated before, they need to inform but not control the discussion. They need to inform the discussion, not control the outcome.
Information that we will make our decision.
Quality assurance.
From the quality side and from education here, right?
For them.
Yeah, I was gonna say to her point, wouldn't that would make sense? That, if QA/QI is seeing something on a system basis that we should in the education department know, so we could actually have some data driven information is to know what direction we actually do.
Luckily enough, Dr. Young is the chairman of the QA
very-
committee. And so for meeting integration, yes, we have it's there.
Wait, that was wonderful. You, yeah,
I pass. I learned that in EMS manager school.
Can I just say that I agree that the data from the hospital needs to not be anecdotal, that one doctor says this is what this is. That's one of the things that Dr. Jensen did. He had the good data to show about babies being cold. And we have to, it goes both ways. We have to get the data that shows a trend, not one person saying that this is what we should do.
All right, do we all have a
Follow up with the QAQI reports.
Yeah.
To education to drive discussions.
All right, we're running out of time. So let's move on to the next thing. The next item on the agenda is the mentorship program and preceptor education. First of all, I'd like to know, how is the new system working for those that are using it and haven't any big issues? I've heard good things about it mostly. Got a couple of little rough hurdles, wrinkles to iron out, but I think those are ironed out now.
I know we had to paramedic proof a few of the pages to make sure that it didn't get accidentally overwritten and screw up the data, but other than that, protecting some cells, life was good.
I think so. There was there were two issues that we found in the way that it was written. It's on the document that Nicole put out for everybody to use. The 70% and the 80% can be read the way that it's put into first phase and second phase, is that they have to pass critical calls at 70 and 80%. That's proven to be an issue percentage wise. I think we need to take that 70 and that 80% out, because we already know that you have to pass phase one with 70% total. So it takes into account every call. It's all the calls, all the ALS calls go into that 70%. And the same with the second phase at 80%. But they may, if they fail 2 out of 4 criticals, that's 50%. We're hamstringing ourselves, I think, there with a separate percentage on the critical fall, when it's already counted in the 70 to 80% overall. And so I wanted to bring that to everybody's attention so we can make that happen.
Now, just correct me if I'm wrong, sorry. Last time there was a packet that we didn't have the packet for the new updated packet and the packets, and that's fine. Did the waterfall grading stay?
Oh, the Eureka, you mean?
Yeah, the Eureka.
Nothing's changed. Everything is in there except for that. Say, we're clarifying the 70 to 80% for critical.
Gotcha. Because my understanding was, because I agree with you, if a student fails 2 out of 4 critical calls, 50%, they fail another one or pass another one, they've got this sort of long climb back to.
Correct.
We all have timelines where they need to be done with internship by, otherwise schools are on the hook for that. The Eureka grading was intended to fix that, where if they failed 2 out of 4 calls, by the next one, it should fall off of it and alleviate that. I'm happy to remove the 70, 80%, as you stated. But I thought that was the intent of the Eureka grading. So I just want to clarify that point before we, because it should, that those 2 failed calls should fall off by the next 2.
But remember, Eureka takes all ALS calls.
Right, so it's the last 20 calls or whatever.
20 calls in a row show consistency.
So if the 4 criticals were at the very end, it's going to take 16 calls to start dropping off those last criticals.
Anyway,
Another thing to consider with that point as well too, is that style of grading doesn't take effect till phase 2. We do have 2 students that were struggling shifts 1 through 5, but then 6, they started getting it. 7, they started improving. All of a sudden 7, 8, 9, they're doing well, but they're never going to make up from shifts 1 through 5.
Yeah.
And so that's, again, to your point, that is another grading aspect that we might want to look at. That waterfall or Eureka style of grading probably should be in phase 1 as well too. Because right now it's not. Good thing to consider moving forward though.
okay. If you guys want to think about that, bring that,
I mean, but in the interim,
Agenda item.
I think your proposal was to remove this is what I understood, so correct me if I'm wrong, but it was to remove the 70% requirement for critical calls in phase one, remove the 80% requirement in phase two. However, students must pass 3 critical calls at any point in phase one and phase two, for a
Correct.
total of 6 successes.
Correct.
And that's a change that, like, again, to help students that are out there right now struggling to overcome a percentage, if we can do that, that would be ideal. And then take this back in April, so we don't have 2 months of students, oh, well, I failed because,
Yeah, no.
right? Like,
And then, like I said, the way it was written, that's not the end.
right.
And so we're trying to clear up. It's still 70%, 80% for the phases total, still have Eureka. All the things that we worked on for the last year are still in play, just to clear up that.
Is there any major internship? I mean, do we have a big group of interns going right now?
I have 25 out. right
Oh,
now.
do you?
Yeah.
I was saying because that'd be great and put together a proposal for, or is this going to be in motion today?
It's good for today to clean that up so we can
For
move
a
on
quick change.
and put it up, and then we could talk about the Eureka next time. Okay,
Re-agendize it for next time as well.
what's that?
Bring it back for next time too.
Yes.
Didn't make a motion today, so the motion is, unless there's more discussion.
Any more discussion from this end?
So the motion I would make is to make a change to the internship mentorship program to remove the 70% success requirement in critical calls in phase one, remove the 80% success rate on critical calls in phase two, and replace that with student must successfully complete 3 critical calls in phase one and 3 critical calls in phase two. That's the,
How would the math work out? This isn't gonna happen, but playing devil's advocate. Sure. They get 3 successful critical calls in phase two, but they drop the ball on 4 other ones. So that means their ALS exposure, right? Because those would be ALS calls. Depending on how many ALS calls, they could still maybe pass them.
yeah, that's a fair point, because I mean, I guess the argument or the hope there would be that the 80% success overall would start to drop at that point. You're right, though. They could knock it out of the park, have 100% success.
But whenever they have a stressful call,
What if
they
they have-
just shut down. I think it's worth, I'm cool with emotion, like, but somebody better than me should probably do the math and see how bad this could get.
Oh, no, I agree with you. I totally agree with that assessment. It's just, I think more commonly what I see anecdotally is a student will fail their first 2 critical calls in phase one. They're new to the internship. They get them early on. And now we're here at shift 15 and we're like, you just got to pass 6 more and then you're going to be good.
Sure.
And then it's like, well, now can we get them 6 more critical calls? Can we find that? Can we just hope and pray? Like, and
Maybe that's the problem we solve after this motion passes. We see what happens in the long run and then we solve that problem next.
yeah, no, and I totally agree that the motion is a temporary measure so that we can discuss more in depth the Eureka grading for phase one and critical call Eureka grading if we want to have that a separate metric that also clarifies.
I have a question though. So we're saying we're gonna drop the percentages. We're gonna say 3 critical calls in both phases. They don't have to be critical calls. They can be simulations. So not all simulations are created equal. So it could be, I'm running a simulation in the truck in a month. Versus a student who's running 3 cardiac arrests
Absolutely.
or a neonate.
Yep.
Do you know what I mean? So, chief point, right?
That was the argument way back even in the working groups was, I think the same point was brought up. Not all sims are created equal. We've seen the back of the truck sims and we've wanted to define simulation and that all of a sudden opened a can of worms. I agree. I would prefer that the agency and the school were involved in a simulation in order to count it for an internship. Because
This is just saying no passing percentage, and then we can have 3 calls. But the critical calls are either a call or a sim or whatever.
or a back of the
Or
truck.
whatever.
Do you want to put language in that simulations that count towards critical calls need to be conducted by the school and the agency together?
Just go. Exactly.
That's too criteria.
Right. Right.
Oh, I did because then we were
Giving payment.
Right.
like threading needle. But then at this point, it seems like we've gone all the way to the other side where we're like, whatever.
Well, we can rein that in right now. I mean, while we're making the motion, that could be something that you add to it is if simulations are going to count towards those critical calls, the simulations need to be conducted together.
So every EMS education we put out to our people has to be approved by the health district, correct? That gives us the hours required for that specific category of CMEs. I have a deck of maybe 10 Halo events that I put my students through that are in varying degree of difficulty. What if we just, as a committee, as the education committee, we get our Halos, our critical calls, the scripts that we have? Because I might have some ideas, but you guys might have others. Let's get them approved through the health district like we would for any CME hours. That way we know the scenarios we're running are critical by the health district standard. But then we also have a grip of these that I could pull from a deck and say, my intern's struggling with a drowning call or a MCI or whatever. And I don't have to go through the legwork of creating that intense scenario because we would have a list through the health district.
And how are you going to keep those secure?
Yeah, that was.
I was hoping you would.
No. Nice try.
Keep it in my liquor cabinet. I have
What if we added on there? What's that, bud? What if we added on there the criticals second? That way, if they do fail the first two, three. So we need to keep that part simple. Again, this is not a major change. It was more to clear up the interpretation. And remember, we have not changed the 80%, 7% mark for phase 1, phase 2. So if they fail 2 criticals, that's going to be counted in that 70 and 80%. And if
So we're keeping the percentage.
The overall
the
percent,
overall percentage, not just
but just not.
not applying it to critical.
And I'd be happy to amend the motion to say that a critical call that is substituting, or a simulation that is substituting for critical call shall be overseen by the agency and the training institute. Would that be?
Yeah, I
probably
we
fix it.
still say.
I know, I totally
We
agree.
need to have a small, because
Yeah.
we've all seen. and
Yes.
Is it where you get to the end of the last pages, sing.
Yes.
Did someone second that motion?
No, we're still amending.
Well, you have 60 students that all need 3, like you're gonna somehow meet up with us and do the simulations?
Well, so like
Only
my
if there's
50,
not criticals, but I think you're gonna
the
get.
50 in cohort 6, none of them have needed sims. They've all gotten their numbers.
And most of ours also.
Yeah, it's a small number.
We do, regardless of how many numbers they have in the streets,
You
we
do your
do
own deal.
critical Halo calls as scenarios at the beginning, the middle, and the end. So that's a strong point that she makes it. The school's gonna have the time to schedule with our schedules, how to do that.
And I mean, it could just be signed off by the training institute if there is, but we do, and anytime we're simulating critical calls, we find a way to get out to the agencies and make sure that those are overseen and at least signed off on the validity from our perspective that we believe it simulated critical and realism.
Then back to Laura's point, what if we just submit our critical calls that we do for scenarios to you guys for you guys could be the keeper of those. If I need help coming up with, hey, I need a critical call for an MCI, do you guys have one for me?
Yep.
Maybe that's you guys.
Yeah.
Do that. And then you guys don't have to Rebecca's point, get to every agency at our schedules when we're there, plus our students are there to do scenarios. Because the scheduling from my agency enough is trying.
That should probably include the rubric as well associated with the scenario. So then each individual knows that these are your passing considerations for this scenario. And then the agency that's working the scenario says, these are the things you have to hit. I think there should be a rubric involved there as well.
We can flesh that out next meeting.
Okay. So are we good with the amended? So it would be to remove the critical percentages, 70% criticals in phase 1, remove the 80% successful criticals in phase 2, change that to 3 successful critical calls in phase 1, 3 successful critical calls in phase 2. If simulation is being used to substitute a past critical call, the agency and training institution will have to sign off on the validity of the sim.
That's fair.
That's the motion. This
Do I
is
have
the-
a second? Hurry, please, somebody second it.
Second.
Awesome. Any more discussion? Any opposed? Awesome. What we'll do.
Someone say aye.
Aye.
There you go.
I didn't hear anybody opposed.
Be-
Put it that way.
Before we
The rules are
adjourn,
here now.
I'm assuming you guys getting ready to adjourn. I wanted to just make just since I have you all in one collective spot. If any of your agencies are needing an instructor 2 course, we're doing an instructor 2 course based on the Foundations of Education book that we're also providing to that, doing it February 20th and 27th. So if anybody's got people that they're wanting to send, let me know, and we've got spots for you.
We also sent out a sign up to we're doing the EMS 1 instructor course at the end of this month.
An instructor workforce.
Yep. So if anybody needs that, let
What's
us
your
know.
dates on it, Troy? Do you remember?
23rd and
23rd,
26th, then
26th, 27th.
Okay, I was gonna say, yeah, if you need to coordinate it, then we can.
All right.
We'll have it covered in February.
Yeah. Okay, let me think. So, any more public comment? Second chance for public comment. Do I have a motion to adjourn?
Adjourn.
Second.
Let's move.
Victor called McLean. Finding a way to manage the